manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The following information represents American Heart Association guidelines and best practices for measuring and improving the basic life support skills of the teams you work with. The guidelines recommend that healthcare providers tailor the sequence of rescue actions based upon the presumed etiology of the arrest. ACLS providers functioning within a high-performance team can choose the optimal approach for minimizing interruptions in chest compressions. There are different protocols to maximize chest compression fraction and high-quality CPR. High-performance teams are essential to successful resuscitation attempts and can translate to improved survival for patients in cardiac arrest. High-performance teams effectively incorporate timing, quality, coordination, and administration of the appropriate procedures during a cardiac arrest. In addition, these teams clearly identify their overall purpose and goals. They are aware of the skills each member possesses and not only understand each team member's motivation, they know their strengths and weaknesses. High-performance teams also incorporate effective conflict resolution and communication skills. And last but not least, high-performance teams continually measure their performance, evaluate the data, look for ways to improve performance, and then implement those learnings. One of the measures of a high-performance team is the ability to achieve specific performance metrics and a high chest compression fraction, or CCF. CCF is the amount of time spent doing high-quality chest compressions during a cardiac arrest event. You can only achieve a high CCF by eliminating pauses during high-quality CPR. The Resuscitation Outcomes Consortium, or ROC trials, showed that a 10% increase in CCF is roughly equal to an 11% increase in survival. Pauses typically occur during intubation, rhythm analysis, pulse checks, compressor switches, and defibrillation. We'll address some best practices for eliminating pauses in some of these areas, but you'll also need to measure high-quality CPR metrics at your own place of practice to identify other areas where pauses exist. You can't improve what you don't measure. Whenever compressions are paused, compressors should hover over the chest and be prepared to resume compressions. 15 seconds before pausing compressions at the end of each 2-minute cycle, high-performance teams should check for a pulse as a placeholder, pre-charge the defibrillator, and be prepared to deliver a shock in 10 seconds or less.
145.
Okay, let's go ahead and charge up.
Charging.
Do we have good pulses with CPR?
Good femoral pulses with CPR still.
All right.
6, 5, 4, 3, 2, 1. 2 minutes.
Okay, let's stop CPR.
No femoral pulses without CPR.
Okay, that's a shockable rhythm. Shock.
Clear to shock. Shock delivered.
CPR.
Starting 2 minutes.
Okay.
Switch compressors.
Okay, we have a bradycardic rhythm. Pulses?
No pulses
No
without CPR.
pulses. Let's continue CPR, please.
For seamless transitions, switching between cycles every 2 minutes is best. However, if a compressor needs to switch because of fatigue, coordinate the switch to happen as fluidly as possible.
3, 2, 1, switch.
It's a best practice to use real-time feedback devices during CPR. However, if a feedback device isn't available, a metronome can help establish the proper rate. If your AED or defibrillator doesn't have a metronome, you can download a metronome app to your mobile device before the conclusion of this course. Successful high-performance teams also practice good communication skills and adhere to the key elements of effective team dynamics. These elements help teams work together in the most efficient way possible.
Damn, he don't look emaciated.
The American Heart Association has grouped the elements of team dynamics into 3 categories: roles, what to communicate, and how to communicate. Clear roles and responsibilities should be immediately established by the team leader or the first rescuer on the scene. When all team members know their roles and responsibilities during a resuscitation attempt, the team functions smoothly. Every member of the team should know his or her limitations. Team members should ask for assistance and advice early, not when the situation deteriorates.
I'm getting pretty tired of these compressions. You need some help after this?
Sometimes a team member or team leader may need to correct actions that are incorrect or inappropriate. It's important to be tactful, especially if you need to correct a colleague before they make a mistake.
And now you're too fast. Target heart rate is 110.
The next category is what to communicate. Knowledge sharing and summarizing information are critical components of effective team performance. Team leaders should review what's happened and ask for ideas and observations from team members.
Can you give me a recap, Nick?
Yes, we've been doing CPR for about 4.5 minutes. We've got 1 shock, 2 no shocks, and you've given 1 dose of epi-IV.
Okay, anybody have any ideas on what else we can try with this patient?
Finally, how to communicate. Closed-loop communication is the process of verifying that the message sent was received as intended. It also verifies that any assigned tasks have been completed. In addition to using closed-loop communication, teams should use clear messaging. Concise, clear language helps prevent misunderstandings. Teams that work together frequently can create terms or phrases that have specific meaning for them to ensure clarity among members.
145.
Okay, let's go ahead and charge up.
Charging.
Do we have good pulses with CPR?
Good femoral pulses with CPR still.
Finally, teams need to communicate with respect. Speak to each other in a professional manner, regardless of scope of practice or expertise. Resuscitation events are stressful, and emotions can run high. Understand that this is the nature of CPR, and remember the life you're trying to save. Not only is it important to know what to do during a cardiac arrest, but it's just as important to know how to work together as a team during an event. Debriefing as a team is an important component of every resuscitation attempt. Such debriefing during and after an attempt helps individual team members perform better, and it may also bring system strengths and deficiencies to light. Implementation of debriefing programs may even improve patient survival after cardiac arrest. It's not enough to know what to do, or even how to do it. To obtain the best results, your team must perform both the what and the how flawlessly. That requires practice, and effective practice requires measurement. But measurement is only effective if you debrief the team, set goals to improve, and practice more. Remember, you cannot improve what you do not measure. For more information on how your team can implement this type of program, please ask your instructor for more information. A 66-year-old man has arrived in the emergency department with nausea, chest pain, and numbness in his arm.
So you say you're feeling bad about an hour ago?
Yeah, I was getting dizzy. I felt nauseous.
And you're having some chest pains?
Yeah.
We're gonna find out what's going on.
Pressure is 70/40, heart rate is 45. I'm gonna get Dr. Loftus.
Mr. Haley, I'm gonna put you on some oxygen so you breathe a little easier, okay?
Okay.
I'm also gonna put you on a monitor so we can take a look at your heart rhythm.
I'm really dizzy now.
Hi, I'm Dr. Loftus. Looks like sinus bradycardia.
Initial blood pressure was 70/40, heart rate is 45, respiratory is 16, and pulse ox is 92. But he's responding well to the nasal cannula.
Let's get 1 milligram of atropine ready, though.
What's going on? Is something wrong?
I don't know, son. Nurse?
His heart is beating too slow, so we're gonna see what the doctor thinks, okay?
Hello, I'm Dr. Loftus. How are you feeling?
Not so good, doctor.
Mr. Haley, can you hear me? He's unresponsive.
He's in VFib. Lenore, get the pads on, get ready to shock. Mark, start chest compressions.
Ma'am, I really don't want my son to see this. Is there anywhere I can take him?
Absolutely. If you'd like, I can show you to the family waiting room.
Okay. Come on, let's go.
Pads on. Charging. Clear. Shocking. Shock delivered.
Resume compressions. Dana, you're recording.
Recording.
Sam, you're managing the airway. Lenora, have you managed to establish an IV?
No, I'm not able to get IV access.
Okay, Carla, let's move to IO.
Moving to IO access.
We'll continue CPR for 2 more minutes, and then we'll evaluate to see if we need additional shocks. In the meantime, Carla, can you prepare 1 milligram of epinephrine, but don't give it until I say so.
Preparing 1 milligram of epinephrine, and we'll wait for your order to give it.
Wait 2 minutes.
Hold compressions. Switch compressors. He's still in V-fib.
Clear. Shocking. Shock delivered.
Resume compressions. Okay, Carla, go ahead and deliver that epi now.
Delivering 1 milligram of epinephrine.
And the IO is flushed.
Okay, great. We delivered 2 shocks and 1 milligram of epinephrine. If the patient's still in V-fib at the next rhythm check, then the next medication to consider is amiodarone. So Carla, go ahead and prepare 300 milligrams of amiodarone, but don't give it until I tell you.
Preparing 300 milligrams of amiodarone, and we'll wait for your order to give it.
Wait 2 minutes.
Okay, let's analyze. Switch compressors. Looks like the patient's in persistent V-fib.
Clear. Shocking. Shock delivered.
Continue compressions.
Do you want to give the amiodarone now?
Thanks, Dana. Carla, go ahead and give that amiodarone now.
Delivering 300 milligrams of amiodarone.
And the IO is flushed.
Great. We've delivered 3 shocks. After the second shock, we gave 1 milligram of epinephrine. We just gave 300 milligrams of amiodarone. Go ahead, Carla, and prepare another milligram of epinephrine, and I'm going to intubate.
Got it.
2 minutes.
Let's analyze. Switch compressors. We have sinus bradycardia. Do we have a pulse?
No, I don't feel one.
Continue chest compressions. All right, let's review the reversible causes by considering the H's and T's.
He came in with chest discomfort. Could it be coronary thrombosis?
That's what I'm thinking. Everything seems to suggest a STEMI.
Patient was also hypertensive on presentation. About pericardial tamponade.
Good idea. Let's check a quick ultrasound.
2 minutes.
Let's analyze. Switch compressors. The monitor now shows sinus tachycardia. Capno just went to 40. Sam, do we have a pulse?
Yes, I've got a rapid weak pulse.
Let's initiate immediate post-cardiac arrest care. We check to see if the patient is breathing and responsive. Lenora,
Speed
any
of finger.
complete set of vitals and labs.
Patient's still unresponsive. No, he's still not breathing.
Okay, continue ventilating.
Patient has a blood pressure of 82/40 with a heart rate of 130.
He's hypotensive. Let's get him another liter of saline. Lenora, can I get a 12-lead ECG, please? And let's check the patient's temperature and initiate targeted temperature management protocol. O2 saturation is 96%, and blood pressure is up to 110/70 now.
Should 12 leave.
He is a STEMI. Mark, call the cath lab and let them know that we have a STEMI patient that just had ROSC after cardiac arrest. Let them know that the patient is now hemodynamically stable, and we've initiated targeted temperature management.
The return of spontaneous circulation, or ROSC, is not the end of the cardiac arrest protocol. The high-performance team should continue to maintain an acute sense of urgency. Patients are still in a toxic state, and the possibility of another arrest is extremely likely. One of the key actions to take is targeted temperature management. It is the only intervention that has been shown to improve neurologic recovery after cardiac arrest and ROSC. The resuscitation team should consider inducing targeted temperature management for any patient who remains comatose after ROSC. The AHA recommends cooling to a target temperature of 32 to 36 degrees Celsius for at least 24 hours. More scientific studies show that survival rates improve significantly with a comprehensive system of post-cardiac arrest care. It's important to know your local system's plan for the management of post-cardiac arrest patients. Combining your knowledge of essential arrest skills with timing, quality administration, and coordination through effective team dynamics can give your team a better chance of success with every resuscitation attempt.
Now, why the target temperature management? Why do we do that?
Well,
Think of physics now.
I know it cools the body, so it can have time to repair.
It slows the metabolism down and allows less damage and more time for the body to heal. That's why you do the target temperature management. Okay? Now, the only thing about the target temperature management that the state says is if your facility that you work for does it, the facility you transport to the most has to do it also, or they will not be able to, you will not be able to do it. So if your hospital don't have target temperature management, you can't do it. It costs $200 for an EMS service to do it, but $200,000 for a hospital.
200,000.
Yes.
For a single patient.
No, for the equipment.
For the setup.
You have to get the hugger blankets that blow out the cool air that wrap around the patient. You have to get the blood coolers where you know they actually tap into the central lines and cool the blood down. That way, they don't do the fluids in the hospital. They actually cool the blood down by cooling the body down, by cooling the blood. So, and they have the bear hugger blankets, which if you've ever seen anybody that was hypothermic, they used the same thing, the bear hugger blankets, to put over them and to warm them back up. Well, they do the same thing, they just cool them back down. All that equipment costs like $250,000. So it's not really up to the EMS service to do it, it's up to the hospitals because of the amount of money you're dealing with. And money is always a factor. Yeah, I understand that you're talking about people's lives, but money always matters when it gets down to brass nuts. If you don't have the money, you can't operate. So
like when you say bear hugger blanket, you mean like?
It looks like a really thin air mattress they put on top of the patient, and they put a bunch of blankets in it.
Okay, that's what I thought you were talking about.
Yeah.
They have those.
The bear hugger blanket can warm you up from being hypothermic, or it can make you hypothermic by cooling you down. And like she said, it's like the ones I've seen look like floats.
Yeah, they're like really thin. And
Yeah, they blow air out, the cold air.
Yeah.
But they lay across the patient and then they put blankets on top of them to cool them down.
That's what you're talking about, but I just want to make sure.
So all that equipment costs money. Now, when we get to the CPR portion, I hate to tell y'all, but y'all gonna have to do CPR on the mannequin, and you're gonna have to use the AEDs, okay? That's a part of ACLS, I'm sorry.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The following information represents American Heart Association guidelines and best practices for measuring and improving the basic life support skills of the teams you work with. The guidelines recommend that healthcare providers tailor the sequence of rescue actions based upon the presumed etiology of the arrest. ACLS providers functioning within a high-performance team can choose the optimal approach for minimizing interruptions in chest compressions. There are different protocols to maximize chest compression fraction and high-quality CPR. performance teams are essential to successful resuscitation attempts and can translate to improved survival for patients in cardiac arrest. High performance teams effectively incorporate timing, quality, coordination, and administration of the appropriate procedures during a cardiac arrest. In addition, these teams clearly identify their overall purpose and goals. They are aware of the skills each member possesses and not only understand each team member's motivation, they know their strengths and weaknesses. High-performance teams also incorporate effective conflict resolution and communication skills. And last but not least, high-performance teams continually measure their performance, evaluate the data, look for ways to improve performance, and then implement those learnings. One of the measures of a high-performance team is the ability to achieve specific performance metrics and a high chest compression fraction, or CCF. CCF is the amount of time spent doing high-quality chest compressions during a cardiac arrest event. You can only achieve a high CCF by eliminating pauses during high-quality CPR. The Resuscitation Outcomes Consortium, or ROC trials, showed that a 10% increase in CCF is roughly equal to an 11% increase in survival. Pauses typically occur during intubation, rhythm analysis, pulse checks, compressor switches, and defibrillation. We'll address some best practices for eliminating pauses in some of these areas, but you'll also need to measure high-quality CPR metrics at your own place of practice to identify other areas where pauses exist. You can't improve what you don't measure. Whenever compressions are paused, compressors should hover over the chest and be prepared to resume compressions. 15 seconds before pausing compressions at the end of each 2-minute cycle, high-performance teams should check for a pulse as a placeholder, pre-charge the defibrillator, and be prepared to deliver a shock in 10 seconds or less.
Minute 45.
Okay, let's go ahead and charge up.
And get ready to rotate.
Do we have good pulses with CPR?
We have good several pulses with CPR. Okay, we're at 2 minutes. Stop CPR.
That's a shockable rhythm. Shock.
So the patient, shocking, start CPR.
Switch compressors. For seamless transitions, switching between cycles every 2 minutes is best. However, if a compressor needs to switch because of fatigue, coordinate the switch to happen as fluidly as possible.
3, 2, 1, switch.
So the patient, shocking, start CPR.
It's a best practice to use real-time feedback devices during CPR. However, if a feedback device isn't available, a metronome can help establish the proper rate. If your AED or defibrillator doesn't have a metronome, you can download a metronome app to your mobile device before the conclusion of this course. Successful high-performance teams also practice good communication skills and adhere to the key elements of effective team dynamics. These elements help teams work together in the most efficient way possible. The American Heart Association has grouped the elements of team dynamics into 3 categories: roles, what to communicate, and how to communicate. Clear roles and responsibilities should be immediately established by the team leader or the first rescuer on the scene. When all team members know their roles and responsibilities during a resuscitation attempt, the team functions smoothly. Every member of the team should know his or her limitations. Team members should ask for assistance and advice early, not when the situation deteriorates.
I'm getting pretty tired of these compressions. You need some help after this?
Sometimes a team member or team leader may need to correct actions that are incorrect or inappropriate. It's important to be tactful, especially if you need to correct a colleague before they make a mistake. The next category is what to communicate. Knowledge sharing and summarizing information are critical components of effective team performance. Team leaders should review what's happened and ask for ideas and observations from team members. Finally, how to communicate. Closed-loop communication is the process of verifying that the message sent was received as intended. It also verifies that any assigned tasks have been completed. In addition to using closed-loop communication, teams should use clear messaging. Concise, clear language helps prevent misunderstandings. Teams that work together frequently can create terms or phrases that have specific meaning for them to ensure clarity among members. Finally, teams need to communicate with respect. Speak to each other in a professional manner, regardless of scope of practice or expertise. Resuscitation events are stressful, and emotions can run high. Understand that this is the nature of CPR, and remember the life you're trying to save. Not only is it important to know what to do during a cardiac arrest, but it's just as important to know how to work together as a team during an event. Debriefing as a team is an important component of every resuscitation attempt. Such debriefing during and after an attempt helps individual team members perform better, and it may also bring system strengths and deficiencies to light. Implementation of debriefing programs may even improve patient survival after cardiac arrest. It's not enough to know what to do, or even how to do it. To obtain the best results, your team must perform both the what and the how flawlessly. That requires practice, and effective practice requires measurement. But measurement is only effective if you debrief the team, set goals to improve, and practice more. Remember, you cannot improve what you do not measure. For more information on how your team can implement this type of program, please ask your instructor for more information. Our simulation will have 6 team members. You may have fewer members, depending on the situation, so be prepared to adjust your roles accordingly.
Yes, I hear them now. Thank you. Honey, listen. Hang in there because ambulance has just pulled in, okay? It's gonna be all right. Everything's gonna be fine. I'm gonna go get her right now, okay?
All right.
Okay. Please hurry. He's looking really bad.
Sir, how you feeling?
Oh, man, it's getting worse. I feel like I'm gonna throw up.
All right, well, we're gonna help you, but I need to ask some questions. Can you tell me where the pain is?
Oh, my chest is killing me.
All right, are you having trouble breathing?
Yes.
Okay.
Yeah.
I'll get the vitals. Great, thanks, Carlos. CJ, would you put him on the monitor, please? Now, sir, I'm gonna listen to your chest. You take some nice deep breaths through your mouth. Nice and slow. There you go.
All right, can you tell me what happened? He was just out cutting branches, and then he came back inside, and I heard him calling my name.
Sir, can you point to where you're feeling the pain?
There.
Can you tell me what the pain feels like?
It's like something's squeezing my chest.
Blood pressure 88/70, pulse is 180.
Looks like VTech. Prepare to cardiovert. He's fibrillating. Let's move him.
Engine 24, we have arrest. When you get in here.
Carlos, I need you starting compressions now. Lieutenant, please record.
Recording.
CJ, I need you on airway.
Charging. Everyone stay clear. Shocking. Shock delivered.
Get back on the chest. Eva, can you get an IO?
Seconds to go.
Charging.
Notice, he's not running any machines. He is running the code. Now, yes, in the beginning, you may have to do this, but when everybody gets there, you run the code, not machines. You make sure everything gets done if you're in charge and you're the team leader. Okay, if you're not the team leader, everybody can't be leader all the time. I've run into a code with my daughter, and she had 8 years versus my 20. But I didn't take it from her. I asked her what she needed. She said, Daddy, get me an airway. I tubed his ass. That's what I was asked to do. So why would, treat people with respect regardless, okay? There's no need to holler at nobody. There's no need to get irate, because if you ever lose control of that code, you won't never get it back. You might not understand what I'm saying, but one day when you see it, you'll know exactly what the hell I'm talking about by losing control of it and it going south. And you'll never gain control of that code again.
Charging.
Hold compressions for a moment. Switch compressors. He's still in VFib. Prepare to shock him again at 200 joules.
Clear. Shocking. Shock delivered.
Resume CPR. Eva, let's give him 1 milligram epi.
Preparing 1 milligram of epi.
Thank you.
Epi delivered. IO is flushed.
Prepare 300 milligrams of amiodarone, but don't give it yet.
Preparing 300 milligrams of amiodarone.
Let's review potential reversible causes.
I think this is VFib secondary to a STEMI. Charging.
Hold compressions for a moment. Switch compressors. Looks like he's still in VFib. Eva, shock him again at 200 joules.
Clear. Shocking. Shock delivered.
Let's get back on the chest. Eva, give him the amiodarone.
Amio delivered. And flush.
Thank you. Hold compressions, switch compressors. Looks like we have an organized rhythm. Do we have a pulse?
I don't feel a pulse.
It's PEA then. Resume compressions. Let's give him another milligram epinephrine.
Preparing a milligram of epinephrine. Epinephrine delivered. And IO flushed.
Thanks. Go ahead and insert an advanced airway.
Tube in.
Good breath sounds.
Capnography is 15.
Capnography is up to 35. Hold compressions. Does he have a pulse?
We have a pulse.
Looks like he's in sinus tech. Can you give me a new blood pressure? Is he breathing on his own?
Nope.
Vitals BP 86/42, pulse 110.
Okay. Let's do another liter of saline. Continue ventilation once every 6 seconds.
Pulse ox 95%. Capnography 56.
Lead shows a STEMI.
You guys about ready for the stretcher?
Yeah, I think we're ready to move. We're going to take him to Memorial Hospital because of a cath lab.
Okay.
The return of spontaneous circulation, or ROSC, is not the end of the cardiac arrest protocol. The high-performance team should continue to maintain an acute sense of urgency. Patients are still in a toxic state, and the possibility of another arrest is extremely likely. More scientific studies show that survival rates improve significantly with a comprehensive system of post-cardiac arrest care. It's important to know your local system's plan for the management of post-cardiac arrest patients. Combining your knowledge of essential arrest skills with timing, Quality administration and coordination through effective team dynamics can give your team a better chance of success with every resuscitation attempt.
I got a question, Bill. So, let's say you do get Ross.
Hey, how you doing? I think I'm in the wrong place.
All right.
It's thing for CPR class. You know where they say by chance?
No, I do not. I don't know where they're at, but I know they're having it.
Okay.
Across the hall.
Yeah.
All right, thank you. Appreciate it.
Yes.
When you do get a rhythm back, and it happens to be, sinus tech or sinus Brady, you're gonna leave him in that rhythm and just proceed with post-cardiac, with the Ross?
Okay. Good question. If you have tachycardia after an arrest, it's medication induced. Don't fuck with it. Even if it's in the 180s. Okay? Don't mess with it. Leave it alone, it'll come down. Once the medication starts wearing off. If it's bradycardic, you may have to speed that up. It all depends on the hemodynamic stability of the patient. But as far as tachycardia, that's going to be medication induced. Yeah, epinephrine. Y'all go ahead and pass out the mannequins.
I got a question. So what was the drip that he